record. Okay. So, hi everyone. Welcome to the medicine webinar hosted by Titan Robotics Club. We're grateful to have you all here, and today we are joined with Dr. O. Dr. O is the director of the Health Services Research and Development Center of Innovation for Veteran-Centered and Value-Driven Care at the VA Puget Sound Healthcare System and a professor of medicine and pharmacy at the University of Washington. His research focuses primarily on the quality and delivery of care for patients with chronic lung diseases, in particular for patients with COPD. His research program encompasses a number of areas that utilize clinical research methodology, including clinical trials design, comparative effectiveness research, implementation sciences, health services research, and clinical epidemiology. One of his primary research focuses is on identifying and intervening upon potential gaps in the quality of care for patients using population management approaches coupled with nudge-type interventions. And with that, we will have Dr. O share more information about what he does.
Hey there. Thank you for having me. Let me share my screen. Can you see my screen?
Yeah.
Slideshow will actually do a slideshow. Yeah, there it goes. Okay, well, thanks for having me. I would prefer that this is a kind of a discourse as opposed to like a formal talk or anything like that, although I prepared a few slides to kind of get the conversation going. I think these are some additional readings. These are places where I will oftentimes go just to kind of sit and reflect. There are a lot of smart people at the National Academies of Medicine, and they take a societal perspective on kind of healthcare delivery and the like. So it would be great if you would go there some point in time. There's another place called the Institute for Healthcare Improvement, or the IHI, and they talk about this thing called the triple aim, sometimes called the quadruple aim now, but the triple aim is really the idea of like, how do you balance population well-being, the individual patient, and the healthcare costs, which are all important drivers of medicine right now. And the triple aim or the quadruple aim. The quadruple aim, the fourth aim, is actually provider well-being, but in the context of this kind of talk, it's really about the triple aim. And they have a lot of interesting kind of thoughts as well about how do you kind of drive quality and matching value associated with that. And then there's this guy by the name of Aventis Donabedian. This is a Donabedian model of quality of care. And you talk a lot about structures, like what are the structures, like what are the brick and mortar kind of structures? What are the kind of the personnel infrastructure that you need to be able to deliver high quality care? What are the processes of care? So, how do you actually, deliver the actual services? And then the question is, what are the outcomes that you measure to know that you're actually providing high quality care? And so it's a relationship between structure, processes, and outcomes, which are really key to understanding how you drive quality of care within medicine. So what do I do? Well, I am a pulmonary critical care doctor, meaning that I take care of people with lung diseases, and I don't do it very much anymore. I haven't done it in a while, actually, but I used to take care of people in the intensive care unit. And that's what a lot of you heard about during the pandemic outbreak, was not only hospital capacity, but a specialized place within the hospital called intensive care units. And that's where we take care of kind of the sickest of the sick. I'm mostly a health services researcher, so I try to figure out how do you deliver high quality services, or how do you provide services in new and novel kind of ways. I'm also a professor of medicine at the university, the UW School of Medicine. And so as in these roles, I take care of patients. I teach trainees how to take care of patients who have lung disease in particular. I teach trainees how to do research. And as part of that, training them how to do research, I also teach them how to understand the literature. There are literally millions of papers out there, and some of them are better than others. And understanding which ones are good ones and which ones are bad ones largely have to do with how you understand the methods that they have been utilizing. And my research really, and really what I do otherwise, I really do try to improve the quality of care for patients who have COPD or for lung diseases in general. And then as also part of my job within the VA, I help determine policy that affects delivery of care. So I help write policy that governs how physicians and healthcare institutions that are under our domain behave. And so those are kind of the major things of what I do. In terms of the research that I do, really health services research looks to improve the quality and value of healthcare delivery. And so maybe this is a good opportunity to kind of ask some questions of the audience, and you can either put yourself on camera to raise hands or just to kind of reflect right now. Hold on a second. How many of you have been to see a doctor? And my guess is that, most of you, if not all of you, have gone to see a doctor at some point in time. You need to go to a doctor to, for example, to actually go to school, right? You need to get your vaccines. You have to have a yearly physical. If you do sports, that kind of stuff, you need to have physical exams and the like. But how many of you have been to see a doctor and have received antibiotics for something like a bad cold, where you've had fever, cough, phlegm production? Or how many of you have received antibiotics for an ear infection? Did you get a chest X-ray as part of those examinations? And so most of us go to the doctor. At least when I was your age, I would go to the doctor, and I would assume that they knew the right thing to do. And the reality is that there are a lot of times that we will go to the doctor's office and we'll get antibiotics or we'll get a chest X-ray, when in fact those things are actually not recommended practices to do. And so the question is, how do you know that when you see a provider that they've done the right thing? It's kind of not a great thing that you want to think about, because you want to go to the provider and say, oh, they have my best interest at heart, which they probably do. And they know what the right thing to do is, which oftentimes they do, and oftentimes they don't. And then I also ask questions. And so how do you measure that? How do you know when you've had high quality services? That's one of the key kind of questions of health services, is asking the question, was the quality of care that you received good or not good? And then we start to talk, the pandemic has taught us a lot, right? Before, you would go to the doctor's office and they would put their stethoscope on you. They would listen to your heart, your lungs. They would look into your ears. They would have you open your mouth and say, ah. But part of the questions that we're beginning to ask are, what are the things that doctors do? That do they actually provide new information, or do they provide, are they essential in kind of the routine practices of pediatrics, for example, or general internal medicine or pulmonary medicine for that matter? And really, we start to then really tug at the questions of, why is healthcare delivered in the way it's delivered? and can we do it better? And so that's really what my job is. My job is to ask the question, why do we do what we do? And ask the question, can we do it better? Really, that is the essence of my job. So, and so sometimes we have to ask the question, what does it mean to do better? If you're a healthcare administrator and you're concerned about paying the bills of the hospital, and you're concerned about how much money the hospital is making because you want to pay your employees, or you need to, in some outside of Washington state, there are for-profit healthcare companies. And so you want to make sure that your investors are being paid. Doing better might mean, how do we actually generate more revenue? It may not mean, how do we actually provide better care? And so it highlights the challenge that how to do things better is highly individualized and oftentimes needs to take in multiple stakeholders. So for example, you might say, well, the health administrator doesn't really matter that much, in terms of thinking about making money, except for in rural settings, outside this, in more distant areas, in Eastern Washington, for example, there are a lot of hospitals that have been kind of shutting down because they can't actually afford to pay their staff. And so revenue turns out to be a very important part of the equation of how do you actually deliver healthcare. And although we don't like to think about it that way, it's actually part of the business of healthcare delivery. And so we think, oftentimes that there are some stakeholders that are probably more important than others. In this case, the key stakeholder is probably patients. Like, how do we deliver better care to patients? How do we keep providers from, giving you antibiotics when you don't need them, or doing procedures when you don't need them? And it's actually quite hard because, we have a tendency of justifying kind of our own behaviors. And that's where people like doctors and nurses, physicians and medical assistants come into play, because, we have our sense of what we think is right and wrong, but sometimes that sense of right and wrong doesn't actually translate into high quality care. So when someone has a heart attack and they go and the cardiologist takes them back to an area where they can open up that blocked artery to kind of restore blood, that's a procedure that's of high quality usually. But sometimes cardiologists will take people back and there will be blockages that may not necessarily cause symptoms. And they've been taught oftentimes that a partially blocked artery is a bad thing, even though there are medical treatments that are now available that actually give kind of equal benefit to a patient, so that they don't actually need to undergo the risk of a procedure. And so sometimes it's not necessarily clear, and that's why you kind of need kind of metrics to say, what is high quality care? And like I said, everyone has their own perspective. So healthcare in the US is needlessly complex. There are, if you ask your parents who provides your healthcare, it's actually multiple people. You have healthcare insurers who help provide that healthcare because they help pay the bills. They don't pay all the bills, but they pay a good chunk of the bill. You have the healthcare system that employs doctors and nurses and respiratory therapists and the like to kind of help support delivery of care. You have multiple payers and you have multiple hospital systems that all charge different amounts. So if I go to Swedish, I'll get billed one amount. And if I go to the University of Washington Medical Center, I'm get billed a different amount for the exact same thing. And everyone wants the best healthcare, right? If you go out and you look and you Google, best healthcare, you'll see facilities that come up as delivering the best healthcare. But those, I would suggest, are not necessarily based on, those are oftentimes opinion-based kind of results and not necessarily based on what true quality is. So most people actually don't really know what quality means. And we can talk about a little bit of that more in the kind of open forum, and I'll give you some examples. So what do I do on a day-to-day basis? I do research mostly on a condition called chronic obstructive pulmonary disease. And this young man who's smoking a cigarette, that causes about 90% of the COPD, at least in the US. So for the US, it translates to about 24 million Americans who have the condition. It's the fourth leading cause of death. And for people who have COPD, it actually leads to quite a bit of disability because when people can be short of breath, even just at rest, or when they do like small activities like trying to climb a flight of stairs or walk to the bathroom, they can oftentimes become very short of breath. They cough a lot, and they have a tendency of producing a lot of phlegm. So I don't know if anyone recognizes this guy down here in the bottom corner, the bottom right-hand corner. That's doing the, live long and prosper symbol. That's the original Spock from Star Trek. And his name is Leonard Nimoy, and he developed emphysema and actually passed of COPD. So sometimes, although it's such a common disease, people don't really hear about it like they hear about other diseases. And so it's pretty much, it's kind of a silent killer, except for the fact that it produces so much disability in the country and the world. And so the words emphysema and COPD are pretty abstract. And so these are CT, so CAT scans, computed tomography. And these are 3D reconstructions of the lung. On the left-hand side, in this kind of purplish color, this is actually a pretty normal looking lung. You can see vessels that go all the way out, about 2/3 out of the way. And then the areas toward the edge of the lung are pretty clear, and that represents air with little tiny vessels. The bright white that look like the vessels coming out are actually just that, they're blood vessels. And then there you see areas that looked a little bit domed. I don't think I can point on the presentation, but that's actually where there are divisions within the lung that occur naturally. And you can see this big pipe that's coming down the center that kind of breaks into two. That's called the trachea, and that brings air to the left lung and to the right lung. And then on the right-hand side, you can see that there's a difference between these two images, right? The image on the right-hand side has a lot of big kind of black spaces without a lot of whiteness in there, right? You can see it. This is actually, what I'm going to describe is actually the right lung, but it's on the left side of the body here, or the left side of the screen. And you can see this areas of kind of dark, both in the upper lung zone as well as kind of in this lower lung zone area. And that's emphysema. And emphysema occurs when people inhale tobacco smoke, and that leads to destruction at the very end of the lung called alveoli. And over time, it can lead to these kind of giant air cysts that you see here. And that's the reason why you become short of breath, is because you literally are destroying the lung. So, and like I said, if anyone has any questions or wants to talk anything more about this, just chime in now. There's no reason to wait. But and getting kind of back to quality, the way we make a diagnosis of COPD is using things like history. So how much smoking did they do? Did they have other types of exposures that increase their risk? There's a genetic disease called alpha-1 antitrypsin, which is related to certain gene defects that can predispose you to COPD. There are symptoms. Do you have symptoms that are consistent with it, meaning shortness of breath, cough? What is the physical exam finding? So the physical exam finding, so you imagine that when you put your stethoscope over that big area of blackness on the lung, you don't hear very much. And we call that decreased breath sounds. And that's exactly what you hear is decreased breath sounds. Sometimes, and what happens with COPD is as you destroy the lung, you actually have harder time forcing air out. And so it's called an obstructive lung disease. And you can actually hear this whistling sound that we call wheezing. And it's a very high-pitched whistling sound in the stethoscope. And so that's one of the physical findings of it as well. But the main thing we do is to do this testing that we call spirometry. And spirometry is this test as this person is doing here, where you plug the nose and you put a valve in your mouth and you say, and you're looking at this figure on the left-hand side, starting where it says RV, you take a deep breath in, following that inspiration, take a deep breath in, and then they'll say, blow it out hard, and you exhale as hard as you can. And then you kind of go to where it says normal, and then you keep the respiratory therapist is yelling at you, keep it going, keep it going, keep it going, and your expiration, keep it going, keep it going, keep it going, all the way back down to where you're back to RV. And for all of us on this Zoom meeting, our flow pattern would look just like the blue line. I would expect it to be pretty normal. If you have asthma, for example, where it says expiration, there may be a little bit of scooping in that portion of the curve. But overall, you'd pretty much be normal. That would be my guess. But people who have COPD actually don't have that kind of volume. So you can see the COPD curve is the one in the pink. And the characteristics are that the overall volume of air is smaller. That's why it's within the blue lines. You see that the peak goes up and then it stops early. That's because you can't get the air out. And then you're blowing out hard and you get this kind of scooping pattern. And that's just how the air empties from the lung with abnormal emptying or obstruction. So this is key. And the reason why this is key is that if you go to the average provider and say, I've smoked in my past, I have some symptoms of shortness of breath, the odds are they will give you a diagnosis of COPD. When we know that about half the time that diagnosis will be wrong. And so you need this key kind of spirometry to know that you've actually got the diagnosis correct. And so what do we see kind of in the quality of care for patients with COPD? So this is the graph on the left with this kind of the straight lines is the use of spirometry to confirm the diagnosis of COPD. And these are national metrics called HEDIS, which is generated by the National Committee for Quality Assurance, NCQA. And they benchmark quality of care. And you can see down below, there's commercial, there's a program called Medicare, which is a US government-run organization, healthcare insurer. There's Medicaid, which is there for people who need a little extra assistance in getting healthcare. And what you see is regardless of actually how you pay for your healthcare, it's not particularly good. Only about 30 to 40% of people over many years go on to get confirmatory spirometry. So, and we know that of the people who go on to get spirometry done, we know that spirometry will show that about half of those people who have a diagnosis of COPD will in fact not have that airflow obstruction, so they won't have the disease altogether. Now, COPD is also a really common reason why people get admitted to the hospital. And oftentimes, there are kind of quality guidelines, or there are guidelines for care. And you can ask the question, how often do people who get admitted to hospital actually have, high quality care. And so this is a paper done by a woman by the name of Laura Spies, who went back and looked to see how often do people get recommended care. Well, oftentimes with things like these SABAs, which are things like albuterol, which are puffers, you can give medications called steroids, antibiotics, and chest radiographs. Those things are done pretty often, but not all the time. So these are things that we would expect to see done 100% of the time if you were in the hospital for a COPD exacerbation. And yet you can see that even for things like the short-acting bronchodilator, it's only given about 85% of the time, which means that 15% of people who are admitted to hospital who have this diagnosis actually are not being treated that way. There are things like where you can measure the amount of oxygen in your blood, and that's something called, you can do that through an arterial blood gas. Arterial blood gases also give you another value called, they can actually measure the amount of carbon dioxide that's in your blood, and that's a common problem for COPD. And we see that that's only done about 35% of the time. And then when appropriate, meaning that when your blood levels are a certain level, that you can get kind of assisted ventilation through a mask, that's even done even less. And so you can look at the idea of like, what is like recommended care and what would be ideal care. And you can see that only about 18% of people who are admitted to hospital receive ideal care, which is meaning that they receive all the therapies that they should be getting, for that disease. And so I think the whole point of this slide is really just to say that there is a problem in healthcare delivery around delivering quality, delivering the therapies that we know benefit people, and actually not giving things to people that we know actually don't benefit them or are harmful. And so this is part of the kind of the emphasis of my work, is to try to figure out how do you actually get providers to do the right thing. So we've been doing things, and so like I'm a physician who then went on to get some specialized epidemiology training, but I'm not a data scientist, but I work with data scientists because they can help me answer questions that I can't answer with the skill sets that I have. And so a lot of my work is very collaborative. And really, they allow me to start asking questions in ways that I would not have otherwise thought about, or in other ways that I could address them. So it made, working with data scientists and biostatisticians and other type of people, we start thinking about where people need different types of care. So, so I asked you whether or not, when you went to see your doctor, whether or not you went to their office. Maybe you didn't need to go to their office. Maybe, especially as a specialist, I'll show you some maps in a second, but we are concentrated within usually large metropolitan areas, such as Seattle, Bellevue, Issaquah. But a lot of patients don't live near us. And so forcing them to come in to see us really does represent a barrier to care. We call that a geographic barrier to care. The other question is, when should they receive that care? A lot of people think that they should just receive the care that they want now. And that is not an unreasonable concept if we had unlimited resources. But within the US healthcare system, and really all healthcare systems, there are limited resources. So really trying to say, I want to get my care today, you need to ask the question, if you get your care today, will it change some outcome, some clinical outcome? So if I do a screening test today, will it change the outcome of that, somewhere down the line? In a lot of instances, the answer to that question is no. And so what you want to start thinking about is like, what is the right timing of that care that will actually change the outcomes that you're interested in? And so some care can wait, a month. 2 months, 3 months, 6 months, and will have no effect on that person's well-being over time. Other things, on the other hand, you probably need to be seen within a couple days to a couple weeks. And then there are certain things where even a couple minutes matter, right? And so you want to start thinking about, like, what are the services that you need to deliver and when do you actually need to deliver them in a way that makes sense? And then the question is, well, then also, how do you actually deliver that care? The spirometer that I showed you, well, that's a specialized testing device that may not exist in primary care offices. And so how do you, so we actually have to understand, if you want to get information, how do you get that information is a key component of high quality healthcare. And then the question is, how do we get that care to patients? You know, if you need a CT scan, and a CT scanner can take up, you know, a good chunk of space. Do you need that patient to come to the medical center all the time? Well, in this day and age, you can actually buy CT scanners that fit into a van, and maybe you can bring the CT scanner to the patients so that they don't actually have to drive as far, and so you can decrease those kind of geographic and temporal barriers to care. So this is some work we did a long time ago. These are kind of access maps within the Department of Veterans Affairs. And this was, like I said, done a long time ago. And so there are different types of health services, right? There's primary care, there's mental health services, there's pulmonary medicine, that's me. And if you look at these maps, the purple is where there is access to services. And by access, we mean both temporal, meaning that you can be seen within 30 days and live within 40 miles. And so you can see, you know, like in the Seattle area up in the upper corner, there's pretty good access for both primary care, mental health services, as well as pulmonary medicine. But if you start looking at places like Walla Walla, there's pretty good primary care services and mental health services, but there's no pulmonary medicine access at all. We don't have a pulmonologist in our health system in this particular facility. And then there are places down here near Boise, Idaho, for example, where we have primary care availability, mental health availability, and we have pulmonologists there. But at this moment in time, when we did this work, and like I said, it was done a while ago, there was no kind of availability within their clinic to see people. And the darker green areas are kind of population densities. So you can see that where like areas in Walla Walla where there's no pulmonologist, there's actually a relatively large number of patients. Also by Boise, Idaho, where there's actually a lot of patients and there's no access. These are the places where you can actually start asking the questions, well, why don't we have access? And is it because we haven't hired enough pulmonologists, or we haven't hired enough ancillary staff to kind of help support to bring people in? And this is something that you can answer through data and data science, and is not dependent on medicine. So this forms a collaboration of how medicine can collaborate with other people. And so there are programs that we can send out to the community from within the VA. But the problem is that, where we have services, the community is likely to have those same services. And where we do not have healthcare availability, the community is also not likely to have healthcare facilities. And that's actually predictable using data as well. So these are geospatial maps of access, and where we know that, and so these are actually statistical, these are GIS, so geographic information systems. All patients are geocoded. And then we can ask the question, if we make a referral from primary care to pulmonary medicine, how often are we successful at actually getting that patient seen by pulmonary medicine? So your providers, for example, may have made a referral for you to see an ENT doctor or an allergist or some other kind of doctor. About a good chunk of those referrals actually never lead to care. And that can happen for a number of reasons. Maybe your parents said, you know what, I don't want to do that. It sounds kind of stupid. Or maybe that the allergist or the other person, the specialist, was booked out 6 to 9 months, and you're like, I can't wait for that, and you kind of move on. And so there's multiple reasons why, if we're trying to get you, if a primary care doc is trying to get you to a specialist, there's a lot of reasons why that would fail. But as a healthcare system, we need to understand where care is successful and where it's not successful. And using data and data science and data modeling, you can actually figure that out. And you can actually predict that through regression equations. And so this is really just, higher level math that has to be, structured. The data has to be structured correctly, and the right equations have to be written. But this is really how we start thinking about it. So you can see that Washington State is in the middle here, and you can see up in the area near Spokane, there's actually a pretty good amount of pulmonary services available. But if you go towards Chehalis, Washington, or Olympia, there's a lot less. There's the risk of not being able to get a pulmonary visit is much higher. In the bottom left of the corner, that's actually Colorado, and you can see there's in the upper left-hand corner of Colorado, there's a very dense red area. And if you go and look at a map of Colorado, and look at where the population densities are, there are very few people that live in this kind of upper, the northwest corner of Colorado. It's very sparse in terms of population. And that's probably why those people actually, when they get referred to specialists, don't see a specialist very often, because they just don't exist out there. But as a health system, we want to think about, okay, well, if we want to make sure that those patients are doing well, we need to figure out ways to start delivering services out there, so that patients who live in areas where there's not a density of pulmonologists, that they can start being seen. Does that make sense? I hope that all makes sense in the presentation. And the other cool thing that you can do with data science is you can start asking questions around optimization, right? Because we live in a world that has resource constraints. If we wanted to build, capacity across all domains, we could do that, but that would be very, very expensive and probably not an efficient use of resources. Because as you start to build something in one place, that means you're not building something else somewhere else. And so you really do need to start thinking about, like, how do you optimize what you're building? How do you actually take the things that you want to build to really provide the most benefit? And that's where data and data science also kind of helped us, because we can look to see, for example, and these are examples of sound wave tests of the heart called echocardiography. And you can see that within this area near Kennewick, Washington, that we expect to be about 5,700 people, veterans that live out in that area. Of that 5,700, we knew that 179 of them received an echocardiogram within our health system, and 162 of them kind of used it outside the health system. But so together we know, right, that you can add 179 and 162 together, but you can actually project, based on the patient characteristics, how many people, if they lived in Seattle, for example, would actually get an echocardiogram. And so then you can add up those numbers and ask the question, how many patients receive the service, but how many patients would we expect, based on their characteristics, to receive the service if it was ubiquitously or kind of commonly available? And so based on that, you can have an observed to an expected number. And that observed to expected number, that ratio, it represents a gap. So if you build the service in that area, how many more people would you expect to receive that service than actually receive the service, either within our system or outside our system? of healthcare delivery. And so that's really an important way to start thinking about healthcare, because you're not trying to build capacity of healthcare to what people are experiencing, but you're really trying to develop healthcare systems so that they can meet the demand of the health services that are needed by that community. And those things and those numbers are relatively stable over 5-year time horizons, and they can change quite a bit over decades period of time. So this is something that just because you measure it once doesn't mean it doesn't change kind of continuously over time. So on a day-to-day basis, my work really tries to drive how we deliver care to improve really the quality of care for patients with lung disease and other disorders. And that's what I spend most of my day doing. I meet with people, we develop models, we kind of try to figure out how we deliver those models, and then how we fund those models. And really, we focus on issues such as the structure, processes, and outcomes of care. We really do try to bring value in any resource that we expend to the patient, to the provider, and to the health system. Those are very important concepts for us. And I think that's that's kind of like the day-to-day of my life. And so I was also given what's the most important advice that I would give to young folks like yourself. I would say the most important advice is to find the fire in your belly. Like, what are the things that make you happy? What are the things that really kind of engender your interest? Because you're pretty darn young, and you have a long life ahead of you, and you want to do things, and even though you have a long life ahead of you, life is actually pretty short, and the time will fly. The time will go by very quickly. And so you really want to be doing things that you want to do. You really don't want to be doing things that other people necessarily want you to do. But it's really trying to find kind of the things that kind of invigorate you, things that get you up in the morning, things that keep you engaged. People talk about, not working for a living. And oftentimes that means that you would do this job even though it pays you, some small fraction of what they're being paid, or what you're being paid now. And so it's really trying to find what makes you happy and what motivates you. I think early on, especially for young adults like yourself, I think you really want to follow through on what you start. People are always evaluating you. That's just the reality. You evaluate other people. You kind of look at them, you ask questions in your head about them. What kind of people are they? Are they good people? And the like. But one of the things that colleges, advisors, mentors, and the like, one of the things that distinguishes you from others is your ability to follow through on what you start. So if you tell someone that you're going to do something, do it. If it's inconvenient to you, still do it. It's really important because it will help distinguish you from other people in your cohort. And life is a competition. It doesn't have to be a cutthroat competition all the time, but it is a competition. And people are always, if you're judging two items, A or B, they're going to usually take the thing that's in what they think is in their best interest, and demonstrating that you can complete things oftentimes distinguish you from others. I think motivating yourself is really important. Don't rely on others to motivate you. It's pretty common right now for parents to be the motivating force through whatever mechanism they use, either guilt or pressure and the like. I would really listen to what they say because I think they're probably right. But it's really up to you to get your stuff done. And don't rely on others to motivate you. If you rely on your employer to motivate you, that's going to be, they're going to see that as someone who is uninitiated, and you want to come off as being motivated and initiated. It's your life, and many of us up to this point have been pretty sheltered. Like, our parents protect us, they want the best for us, but that only takes you so far. It's up to you to take it to the next step. And so you're going to have to be independent, and you're going to have to take those steps. And I think that's really important. There's a term that I use when I'm hiring people, when I'm evaluating whether or not to hire someone or not. It's like, what kind of scrapper are they? What kind of person are they that they're going to follow through, or they're going to get the job done? What kind of adversity have they been through? And were they able to meet that adversity and dispel with that adversity? Or did that adversity they look at the adversity and say, oh, there's something in my way, I can't get it done, right? You want to be the person who's a scrapper. People who are internally motivated, people who really strive to get things done. That's actually so important. Oftentimes it overcomes knowledge issues. And because a lot of what you learn on the job, or what you need to do a job, they'll teach you on the job. But the key to being successful at that job is to getting that job done. And oftentimes you need to be a scrapper in order to do that. I see a lot of kids that are, and I was probably this way too, that are pretty shy. And I think it's really important to put yourself out there. Don't be afraid. I think the best lessons are the lessons, at least me personally, the best lessons I've learned are the lessons where I felt not great about the kind of job that I did or the outcome that occurred. And so I think it's really important to let yourself fail. No one can win all the time. No one, and even sometimes things that you think you're winning at may not necessarily actually lead to success. And so let yourself fail. Let yourself take some risks, because and then reflect about those risks and reflect about what happened. Don't perseverate on it, but reflect and try to learn from it, because those are probably going to be the lessons that stick with you for your entire life. And they're the lessons that are going to actually drive you forward. Being successful at all the time just means that you haven't taken enough risks and you haven't put yourself out there enough. And then use that thing between your ears. And obviously I'm talking about your brain. Use it early and often, not if. Use it early and often. It's really the most important thing to do is just kind of sit back and reflect. Let me see, I see some things coming in the chat. Yeah, if you have anything, yeah, just feel free to call out now. Let me ask, how do you want to proceed? I mean, I'm kind of through the major talking points. I also prepare some other talking points just based on what you sent me as usual questions. So I can keep on going, or I can pause and open the conversation a little more.
Yeah, I think we can move on to Q&A, actually. That works with Kenny. And
Okay.
yeah, Kenny being...
All right. So throughout your presentation, I made a few questions of my own.
Okay.
The ones that we planned out before, you mostly answered them all in your presentation, so don't need to ask those. While I'm asking these, if anyone has any questions, you can speak up after I finish my few, or put them in the chat and I'll ask them for you. Okay, so later on in your presentation, you talked about the fire in your belly. What about your field made it your fire?
Yeah, I think that's a good question. I mean, for me, I fell into this. I mean, I consider myself, fortunate by serendipity. When I was in college, and it starts back in college, right? I mean, where I was very undecided about I mean, I was a biology major. I knew that I liked science. I was a STEM person through and through. But when I applied to medical schools, I also applied to graduate programs in biochemistry. And so, I really enjoyed what I did, but I didn't necessarily know what I wanted to do with my life per se. It was really I made a decision that I thought I would have more influence and more impact as a physician than as a biochemist. And I think that's in part what drove me to medicine. But I also had, I was lucky. I was an okay student, but I found a research mentor who was very supportive of me. And I think that's really key, is like, you can do what you can do, but there are other people out there, like mentors, who can really help kind of take you to the next level. And when I teach and when I mentor, I try to do that for my fellows and the like, which is just to try to leapfrog a lot of the lessons learned, so that they can actually ascend to levels that are higher than I have over time. And I think that's oftentimes what parents want for our kid. That's what I want for my kids and the like. So and so I had a research mentor who was very good to me, and we didn't spend a lot of time. We weren't best friends necessarily or anything like that, but he understood what was important in the world. And so when it came time for medical school, he advocated for me. And then when I went into medical school, I went back to his lab during research time. And it was not necessarily that I was all that productive in his lab. But he advocated for me. And like I said, it was really a good experience. It was my first real introduction into research, and it was biochemistry work that I was doing. And then it was, when I came to the University of Washington, so I did my medical school at University of Chicago, and then I did my residency at Case Western in Cleveland. And then I came to the University of Washington, and when I applied, I thought I would probably want to do basic science research in pulmonary critical care medicine in the area of immunology. And it was really, just learning and listening. I mean, like, I felt like I was a pretty good clinician, but I didn't necessarily understand. We had this new thing called clinical outcomes research that was really very brand new. And my mentor there was a junior faculty member. And as I was, in journal clubs like this, or I was in other things, I began to really realize that I did not understand medicine the way that I thought I should understand medicine. And that's what drove me to get a master's of epidemiology and do clinical research. So at least I knew that I would be able to interpret the literature in the way that I thought I probably should interpret literature as a clinician. And then as I was doing that kind of work, it led me into this area of looking at how care is delivered. And from there is actually how I kind of, started doing this work. It's all very kind of circuitous and serendipitous simultaneously. It was not like this thing, like I said, when I was your age, oh, I want to be a health services researcher. Actually, to be honest, when I joined the Health Services Research and Development Fellowship Program, which is additional training, I didn't even know what it was. I mean, I was just doing clinical outcomes research, and that's all I thought it was. It was only after that additional training that I began to really understand the nuance. So, you don't have to actually understand exactly what you're doing. You just kind of sometimes have to jump in with both feet and ask the question, is this what you want to do? I mean, the final thing I'll say is that one of my best friends left fellowship a year ahead of me. He graduated a year ahead of me and was out in practice. And with a year left of my fellowship, he called me and asked me if I wanted to join his practice. And, I think back, if I joined his practice, I'd have a pretty darn good life, I think. I would be practicing pulmonary critical care medicine. I'd be a clinician. I might be an administrator of that. But I decided that at the time I was learning how to program in SQL, and I was learning what data was and structured data and just different things around data. And I felt like I didn't give it enough of a shot. I didn't complete that circle. And so I stayed. My friend ended up moving on to a different practice. And but you know, you have to make those kind of decisions. And I don't regret the decisions that I made at all, because I think, you know, you have to kind of know yourself. That's one of the other points I would make, is you kind of have to know. I kind of imagine that after 30 years of kind of doing the same thing over and over again, you might get kind of tired of clinical care and clinical care delivery. But there is nothing that I do on a year-to-year basis that's really the same. It's always changing. So it's interesting. So.
Okay, cool. Looks like we have a question in the chat. What are some structural issues in the healthcare delivery systems you see? And what are some things that you're working on to alleviate these concerns?
Yeah, so I mean, I think the main issue is that, well, it's a very complex question. In US healthcare is badly broken. If you look at how healthcare is paid for, if we did a survey of how healthcare is paid for on this call, there would probably be 20 different, you know, payers of healthcare. Each one have different standards and different approaches. There's also then huge degrees of fragmentation of care out there, so that people who go to Swedish, you know, if you go to the university, it's very hard, you know, to have integrated health systems throughout. And so the structural issues of healthcare, I think I think the payer issues are huge, and they're rooted in our history, because healthcare used to, you know, no one used to provide healthcare. And then employers used to, you know, started using healthcare as an incentive to retain employees. And that's actually how the basis of the insurance company came about, is that it was really an incentive to keep employees with particular employers. And you can see that now in the marketplace. So when your parents work, and you know, they can elect to have health insurance through their employer, and their health insurance and their employer actually offset the cost of the insurance. And so so that is one of the key fundamental issues, is how we actually pay for healthcare. It's very complex. The other thing is, like, healthcare is a business, and it needs to generate revenue. So one of the issues is that you're going to have healthcare where there are population densities, and where there are sparse populations, you're not going to have really healthcare there at all. And is that right, or is that wrong? I mean, that's a societal decision. We have to make a decision about whether or not we think that healthcare is something that we want to provide equitably across, you know, the country to everyone, or whether or not we want to see disparities in healthcare as it exists now. There's disparities based on income, based on geography, based on many different kind of areas, race and the like as well. So it's a very complex thing. And there's no political appetite in this country, as far as I can tell, to actually kind of create more equitable healthcare delivery systems.
Okay, cool.
Yep.
Yeah, that sounds like some pretty big problems.
Yeah, and so you can work on it, and you can work on it with data scientists. You can collaborate with your friends who are CS majors and the like. So,
all right. I have one final question here.
sure.
If anybody has any questions later on, email them to us. You can see the email here. It's flipped, but it's like titanrobotics.com. You can find all the information there, and we'll ask Dr. O about that later on in an email. So final question. What are some good habits to establish in college and medical schools?
Yeah, I think I do think what I said earlier in terms of focusing and getting stuff done. I think actually probably the best thing are develop good habits. And by good habits, you know, like there's a book called like 7 Healthy Habits of Highly Effective People. I think those kind of things are actually right. Are they exactly right for, you know, a college age student or like? maybe, maybe not, but it's really around good habits. It's really around like making sure that you're working diligently to get your assignments done. So you're not cramming at the middle of the night to get things done. Really trying to think kind of, really trying to plan forward. That's probably the most thing that I see is like oftentimes people live moment to moment. And really what you want to do, the end goal is what's 10 years down the road. So you should be thinking about 5-year plan, 10-year plan. And you should be thinking about that every year. And that kind of moves you toward a goal. So having a goal and moving toward that goal, and that goal isn't fixed in stone, right? You can change that goal depending on how your perspectives change over time. But having a goal and knowing and trying to get to that goal, as opposed to just kind of letting life happen. Oftentimes when life just happens, it happens and time will go by. That's one of the kind of the empiric truths of life. And then you'll notice that 5 or 10 years have gone by and you're like, where have I gone? Where's all that time gone? Some of that kind of like wandering time is really good, but it shouldn't be the dominant force in your life. You should really be planning and having habits that really service those long-term goals.
Okay, cool. If you don't have any final remarks, we can wrap up here.
No, just thanks for having me, and yeah, send me any questions you have. I'm happy to pontificate as I can.
Okay, thank you.
Yep.
Can't hear you.
Yep.
Hello?
Yep.
Yeah. Okay.
Yep. Okay. Yeah. So sorry. So that is it for today's medicine webinar hosted by Titan Robotics Club with Dr. O. We hope you were able to learn more or get inspired. And if you want to rewatch this webinar, be sure to check out our YouTube channel at TRC 492 and check out our Instagram at IS Titan Robotics for future news or updates on our club. And yeah, thank you for coming, and thank you, Dr. O.
Yeah, my pleasure. Take care all.
Thank you.
Yeah, you too.
Thank you, Dr. O.
Yep.
Bye.
Okay, I really gotta go. I'm like 10
Yeah,
minutes
me
late for
too.
math class. Bye.
Yep. Bye.